Hi, good afternoon. I'm Giovanna Liuzzo. I am an associate editor of the European Heart Journal's weekly J-Scan section. And this afternoon, I will be the moderator of this very interesting dialogue. The topic is very interesting. It is really important because we will delve into the strategies used for current obesity management and focus on the advent of new anti-obesity drugs, such as GLP-1 receptor agonists, to improve cardiovascular health. That is our mission. As co-moderator, there will be Carlo Patrono, Deputy Editor of the weekly J-Scan, and Massimo Volpe, Associate Editor of the weekly J-Scan, and we will have three excellent guests. Michael Lincoff of the Cleveland Clinic, Timothy Garvey of the University of Alabama in Birmingham, and Geltrude Mingrone from the Catholic University here in Rome. I will invite all the audience that is connected with us, and I see is a very large number of people, to be very active and to ask questions to our guests, writing in the chat. And now it is my pleasure to start this dialogue by introducing our first guest. I take a paper to read because it's a very huge amount of information that I need to give you. And our first guest is Dr. Michael Lincoff. Dr. Lincoff is Vice Chair for Research and in Interventional Cardiologist in the Department of Cardiovascular Medicine at the Cleveland Clinic. All of us know him. He is a professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and holds the Charles and Charlotte Fowler Endowed Chair for Cardiovascular Research. His research activities focus on development of metabolic or antithrombotic therapies to prevent or reduce progression of atherosclerosis or optimize management of acute coronary syndromes and percutaneous coronary intervention. He has served as principal investigator or steering committee member for over 50 trials in ischemic and cardiometabolic diseases. And to start, Michael, I'd like to ask you to summarize for us the results of a very important trial that you led recently, the SELECT trial, also considering the recent FDA approval for semaglutide in adults with cardiovascular disease and obesity or overweight, just to go in deep into the topic of this afternoon. Please, Michael.
Thank you very much, and I'm very appreciative for you inviting me to this meeting. And it's my pleasure to summarize the results of the SELECT trial, which we presented in November at the American Heart Association meeting. Of course, the basis or background is the worldwide pandemic of obesity and overweight. It's estimated that 10 years from now, over half the world's population will have overweight or obesity. And that contributes substantially to the world burden of cardiovascular disease. Until the SELECT trial, no therapy directed at management of overweight or obesity had been shown to reduce the risk of cardiovascular disease associated with overweight and obesity. The agonists of GLP-1, the glucagon-like peptide receptor, are of great interest for a variety of disease states. Originally developed, of course, for diabetes and for glucose control. These agents were shown in randomized trials among patients with type 2 diabetes to reduce the risk of cardiovascular events. And these drugs also lead to weight reduction, and so they've been developed and approved for reduction in weight. Yet it's not been shown until this trial, whether or not GLP-1 receptor agonists would reduce the risk of cardiovascular events associated with overweight and obesity in patients who did not have type 2 diabetes. And so that was the objective of the SELECT trial. That is, among patients who had overweight or obesity and cardiovascular disease, underlying cardiovascular disease, but who did not have diabetes, would the addition of semaglutide, 2.4 milligrams once weekly, that's the weight management dose of semaglutide, known as a brand name of Wegovy, that reduce the risk of cardiovascular events above and beyond the underlying standard of care, the evidence-based standard of care for patients who were being treated for their cardiovascular disease. So the trial enrolled patients who had overweight or obesity defined by body mass index of 27 or greater, who were 45 years or older, and then who had established cardiovascular disease. So this was a secondary prevention trial. They either had had a prior myocardial infarction, a prior stroke, or they had active symptomatic peripheral arterial disease. And those patients were randomized to receive placebo or semaglutide with a dose escalation over the first 4 months to the target of 2.4 milligrams once weekly. The therapy was superimposed upon guideline-based cardiovascular evidence-based therapies. And that's very important because this was addition to the benefit that these patients were also to receive from their secondary prevention medications. And the intent was to be able to show at least a 17% reduction in the risk of the primary endpoint, which was cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And we enrolled 17,604 patients. This was a worldwide trial, 41 countries, over 800 clinical sites. The patients were very well balanced between the two groups. About 27% were women. 70% met criteria for obesity, that is a body mass index of greater than 30. And 2/3 met hemoglobin A1C criteria for prediabetes. Again, patients with diabetes were excluded from the trial. They were well controlled in terms of their risk factors. The mean systolic blood pressure was 131 millimeters of mercury. The LDL cholesterol was 78 milligrams per deciliter. That's the American units. And over nearly 90% were on statins. So this was a treated group of patients. And the mean follow-up was about 40 months, 39.8 months. So the trial showed that the addition of semaglutide to the standard of care reduced the risk of the primary endpoint by 20%. So the hazard ratio was 0.80. Importantly, there was an early divergence of the survival curve. So the event rates began to diverge very early after initiation of treatment, much earlier than for many other therapies, for example, for statins, where there's a lag. This was very early on. The magnitude of treatment effect was similar on all of the pre-specified subgroups, so defined by male or female, by baseline age, by baseline body mass index, whether or not they had prediabetes or not. These patients all had a similar effect on the primary endpoint. The first secondary endpoint was a death from cardiovascular causes, and that was not significantly reduced. The hazard ratio was 0.85, but the upper limit of the confidence interval was 1.01. But death from all cause was reduced, the hazard ratio of 0.81, so by 19%, with an upper limit of the confidence interval of 0.93, so nominally would have met criteria for significance, so a 19% reduction in mortality. The body weight reduction occurred over 65 weeks, which we found to be interesting, given that again, there was a very early divergence in the cardiovascular event curves, and yet maximum weight loss required up to 65 weeks to occur, and was about a 9.5% reduction with semaglutide. And then waist circumference was reduced as well. The effect on the metabolic parameters were as one would expect for this class of drugs. The hemoglobin A1C, of course, was reduced even in patients who did not have diabetes at baseline. In fact, progression to diabetes, the hazard was reduced by 70-some%, hazard ratio 0.27. And among those patients who weren't pre-diabetic to start with, there was a 60 or 70% reduction in their risk of progressing to have pre-diabetes. And A1C was reduced, as I mentioned. The HS-CRP, the inflammatory markers were reduced by about 35%, and the systolic blood pressure was reduced by about 3.3 millimeters of mercury. The treatment regimen was very safe. Serious adverse events were actually lower with semaglutide, driven by the cardiovascular events, but also infectious events, which are interesting. The severe complications of infections were reduced. There was a higher rate of adverse events, gastrointestinal adverse events, that led to study drug discontinuation, about 10% versus 2%. And that's, as is known for this class of drugs, usually early on in the initiation of treatment during the dose escalation. And it consisted mostly of nausea, diarrhea, vomiting. There was a small increase in the risk of gallstones, of cholelithiasis, 2.8 versus 2.3%, but otherwise there was no increase in other adverse events. So pancreatitis, which is of course a point of concern with this class of drugs, we adjudicated that endpoint, and so no difference in pancreatitis, no difference in psychiatric disorders, no other serious adverse events were increased. So from that trial, from the major results of the trial, we concluded that in patients who do not have diabetes, but who do have overweight and obesity and have a pre-existing cardiovascular disease, that addition of semaglutide at that dose, 2.4 milligrams once weekly, to the standard of care did reduce their cardiovascular risk by 20% above and beyond the underlying standard of care. And it did so early on in treatment and uniformly across all the groups of patients that we examined. The mechanisms are we could think about and speculate about the different mechanisms, and the outcome with the treatment was safe. And so this really establishes for the first time, this is the first randomized trial to show a reduction in cardiovascular events with a management strategy aimed at obesity or overweight, and shows us now that obesity and overweight is a modifiable risk factor for cardiovascular disease. As you know, this was submitted as a label extension to the United States Food and Drug Administration, and about a week and a half ago or so, the FDA did approve this as the first therapy, again, for overweight and obesity that's been shown to reduce cardiovascular risk. So they have the additional now indication for reduction of cardiovascular risk. Okay,
perfect, Mike. Let's move a little bit ahead, and then we come back with a lot of questions that I have ready for you. And I see also that in the chat, our audience has already a lot of questions. But please, Carlo, would you like to introduce our second guest?
Let me unmute myself.
The question at the end, otherwise we don't have the time even to to introduce our guests.
Yes, so Dr. Timothy Garvey is an international recognized investigator for his research in the metabolic, molecular, and genetic pathogenesis of insulin resistance, type 2 diabetes, and obesity, as well as for addressing the rational use of newer second-generation obesity medications. He has been the lead author of the American Association of Clinical Endocrinology Clinical Practice Guidelines for Obesity. And perhaps more importantly, he has authored the position statement affirming adiposity-based chronic disease, or ABCD, as the diagnostic term for obesity, which has been endorsed by both American and European organizations. He is professor of medicine in the Department of Nutrition Sciences at the University of Alabama at Birmingham. He's also director of the NIH-funded Diabetes Research Center at the same institution. So, Timothy, I would like to start by asking you to elaborate about the concept of adiposity-based chronic disease and your theory of the set point regulation of body weight.
Well, thank you, Carlo, for that introduction. The term adiposity-based chronic disease is merely meant to be a diagnostic term, not a term that would catch on for general lay parlance. But I think what it does is it emphasizes that obesity is a disease, which when we use the term obesity based on BMI, We sometimes forget that. So, of course, obesity is much more than BMI. It's associated with chronic complications that are really what's responsible for conferring morbidity and mortality and impairing health and impairing quality of life. So the adiposity-based component, it indicates what we are treating, abnormalities in the mass, distribution, and function of adipose tissue. And the second part, chronic disease, tells us why we treat it. As I said, it's a chronic disease with complication, and it's attendant upon us as healthcare professionals to prevent and treat those complications. So it just, once you use that as a diagnostic term, it calls for an evaluation of the patient that consists of both an anthropometric component, and we use BMI for that, even though it's not a direct measure of adiposity, and a clinical component, which is surveilling the patient for the presence and severity of obesity-related complications. So that's kind of the intention behind this term ABCD, and as you indicated, it's been endorsed by both the ACE and the EASO for use in that regard. And the second part of your question, Carlo, was
it's related to your theory of a set point regulation of body weight.
Yeah, I can't claim that as my theory, Carlo, but it's been around for a while. You know, it just, when this is part of written into the pathophysiology of obesity, once, you know, we as healthcare professionals can engineer weight loss, let's say with a lifestyle intervention. But then there's maladaptive responses that are part of the disease. Hormones like ghrelin that make you eat more, go up. Hormones like GLP-1 and PYY, amylin that make you eat less go down. Our basal metabolic rate goes down, which favors a positive energy balance. Our psychological preferences for food conform more to orient us more towards density rich foods, high in sugar and fat content. We're hungrier, and all of these things work against the patient to drive weight regain back up to that previous high equilibrium level. At the same point is if you went to an Italian wedding every weekend for 12 weeks in a row, you would gain weight, right? And then let's say wedding season was over and you started eating, your body would come back down to that equilibrium high level again. So there seems to be a set point around which these satiety hormones and the way they interact with feeding centers in the brain kind of keep us at a high level of adiposity in patients with this disease. You can think about it in terms of obesity prevents obesity. Now, this set point can change a little bit under various circumstances. Some people, it's a little controversial from that aspect. Some people call it a settling point to indicate that it can change slowly, perhaps with aging or after pregnancy, this sort of thing. But this is just part of the pathophysiology of the disease. These patients have a hard time fighting to maintain weight loss because of these mechanisms.
Thank you. We'll get back to you with additional questions after we have a chance to hear the third guest, who will be introduced by Massimo.
It's a privilege to be here today and to welcome all the speakers and our guests and all our distinguished audience, and particularly permit me to say welcome to Professor Braunwald, I can see in the screen. And it's also a privilege to introduce our guest speaker, Professor Geltrude Mingrone, who's an expert of metabolic and bariatric surgery and the effects on obesity and cardiovascular disease. She has focused on the role of the small intestine and insulin resistance, type 2 diabetes, and non-alcoholic fatty liver. Professor Mingrone is an associate professor of medicine at the Catholic University in Rome, and she's also a professor of diabetes and nutrition at the King's College. You know, it's really a pleasure to have you here. And you know, one question that I have is a little bit to animate the discussion is whether bariatric surgery is relegated to the last beach now that we have all these second generation anti-obesity drugs. And And I'd like you to comment on that and see what is the future on that.
Thank you so much, Massimo, for your kind introduction. I'd like also to thank Giovanna for inviting me. I think that in spite of the new drugs, which have really great results, leading to weight loss around 20%, which is unprecedented. So we didn't have these exceptional results before the introduction of GLP-1 receptor or double GLP-1 and GLP receptor agonists. So I am really amazed by the great results on weight loss, glycemic control, and prevention of secondary cardiovascular events. Anyway, I'd like to point out that all these randomized controlled trials focused on people with an average body mass index around 36-38, which is not the target of bariatric metabolic surgery. We cannot imagine that a patient weighing 180 or 200 kilograms can lose an adequate amount of weight just with these drugs, at least at the moment. Perhaps in 10 years from now, we will have even more effective drugs, since there is a huge pipeline of anti-obesity medications. And with bariatric metabolic surgery, we have a weight loss around 35-45%, which is really massive. And we should also recall that 1 in 4 people with obesity, at least in the United States, where we have more data, have morbid obesity, so a body mass index over 40 kilograms per square meter. Therefore, I think that in the future, we can have more options than many options, including metabolic surgery, unless we will find something better, reaching 40% weight reduction, which is not the case at the moment. So I think that there is still the possibility for devices, like gastrointestinal devices, which mimic bariatric surgery to operate in the field of obesity, at least for patients with severe obesity and those who do not respond to the new drugs, because we should also keep in mind that up to 50% of the patients can be no responders, at least with some of these drugs. I'm saying not responders, non-responders, because they can lose 10% body weight, but not 20% body weight. So for 10% body weight, 90%, for instance, with tirzepatide lose weight. But if we are looking at a more pronounced weight loss, about 20% body weight loss, there is a large part of the patients who do not lose weight. And in addition, there are data saying that up to 80% of the patients stop taking the anti-obesity medication within 6 months, which is not well known by all the doctors, but it's the reality. So due to the complications, side effects, the patients who are probably not well followed by their physician stop taking these medications, which is really a pity, since the results are so good.
Actually, if I can just say something, we have a question coming from Leda Galuto that I see in the screen, so maybe Amelia can make her speaking. That is really, you know, adapt to your discussion. So Leda, please make yourself your question. You are the first also writing in the chat. So
okay. Thank you, Giovanna, and congratulations to all the speakers. I'm really intrigued by this class of drugs, and I would like to ask what to expect in terms of metabolic changes and BMI changes during long-term treatment with these drugs, and also how long is for how long we should keep these patients in treatment and what to expect afterwards in terms of BMI and metabolic changes. Thank you so much.
I think the question is for all our guests. So
yes.
all of you, please answer.
Well, I can begin, I guess. That's Leonardo, that's a really good question, a very common question and appropriate. You know, and we only have, when we're talking about second generation medications, we're talking about semaglutide, also tirzepatide, and we haven't heard yet about the tirzepatide trials, but these medications are second generation because they give us 15% or more weight loss on average in phase 3 trials. We only have about 2 or 3 year data at best on these medications. So we really don't have long-term data, and yet we know that obesity is a chronic disease and we need to be committed to lifelong care in essence. So how we use these drugs over the lifetime of the patient, we really just don't know at this point. We do see that when patients stop these medicines, they tend to regain weight because of those pathophysiological drivers that I discussed earlier. And Geltrude is also right. Patients tend to discontinue these medicines. So we have to find ways to keep these patients on these medicines, perhaps at a reduced dose, a maintenance dose, perhaps using intermittent therapy. I have patients that say, well, Dr. Garvey, I've lost my 15% body weight. I'm not losing any more. I don't want to pay for these medicines. Then you need to contract with the patient, go on your lifestyle, keep weighing yourself. But if your weight goes above a certain level, we've got to get back on the medicine. Different strategies like that. But we know we need to be committed to long-term care.
From the trialist or the cardiologist standpoint, I agree that we need to be committed to long-term care, and there are a lot we don't know. We do know from the trials that when treated for 2 years, 18 months, and we stop the drug, about 70% of the patients regain most, if not all, of their weight. We don't know if we went longer, if that set point would ever reset on the basis, you know, that they reach a plateau, and at what point would the body consider that plateau the new set point? I think that's unknown. Whether the weight loss could be maintained with a lower dose or intermittent dosing. I will say, though, from the standpoint of the cardiovascular benefit, I think until proven otherwise, we need to look at it as we would with cholesterol lowering medication or with blood pressure lowering medication, that the cardiovascular benefit would be sustained as long as they're on therapy. We don't know how much of a legacy effect there would be. We also don't know that it's linked to the amount of weight loss. In fact, you know, we're looking into this in more detail with SELECT, and we will be presenting data, but I can say sort of as a preview and as preliminary looks, it does not look like the cardiovascular benefit is necessarily related to the magnitude of the speed of weight loss. So even if patients would perhaps be able to maintain some degree of weight loss after stopping the drug or backing off on the dose, we don't know that the cardiovascular benefit would persist or the degree of protection would persist. So I think, you know, this is certainly, they're expensive drugs. It's certainly something that I think we're going to need to look into in the future, but there's also a lot of drugs in the pipeline and oral drugs and other alternatives that hopefully will come along that will make this easier for patients to take over the long term and less expensive. But I think we should be thinking of this, at least from the cardiovascular standpoint, as a chronic drug for this population of patients.
Actually, you also answered the second of our question in the chat coming from Nick Finner, and you already answered, Michael, because he was asking exactly if there is, if you have data, if we know data about the minimum duration of exposure to semaglutide to provide benefit. So you already answered this question also.
Giovanna, if I can, we give a lifelong treatment for hypertension, hyperlipidemia. So since obesity is also a disease, which is a lifelong disease, we need to treat for the entire life of the patient the obesity disease. So as Tim pointed out, we can alternate one drug with another, so or a ketogenic diet or other lifestyle modification, but we need to keep the patients under treatment for their entire life.
Carlo.
I have a related question for both Michael and Tim on the effect size shown by the SELECT trial. Michael, you emphasized the 20% relative risk reduction in major vascular events as an add-on effect, further reducing so-called residual cardiovascular risk on top of other effective medications. Now, the problem is that when you look at the actual annual rate of major vascular events in this population, it's about 2.5%. And if you apply 20% reduction to 2.5%, you end up preventing 5 major vascular events by treating 1,000 persons for a year, which translates into a number needed to treat of 200 such patients. Now, don't you think that we should ask ourselves whether you can get a similar benefit by acting on other cardiovascular risk factors, traditional cardiovascular risk factors, for example, further reducing their LDL cholesterol level? And related to this, I would ask Tim whether you want to comment on more effective strategies, for example, the dual agonists that seem to provide a double reduction of body weight than seen in the SELECT trial, so about 20% as shown in SURMOUNT trials as compared to 9 to 10% as shown in SELECT. Will this give us further reduction in cardiovascular events? And is this hypothesis being tested?
Well, perhaps I could address that and then come back to the absolute risk issue. First of all, the comparable number for SELECT is probably of 9 to 10%. That's a different population from in the weight management trials, and that's not really comparable. The weight management trials with semaglutide typically saw around 15% reduction, but these are patients who are younger, more women, who had higher body weight. So in a large-scale cardiovascular outcome trial, that's what we saw, and we will see with the ongoing trials of tirzepatide, SURPASS and SURMOUNT, what in large cardiovascular populations, what the weight loss magnitude is seen. But we don't yet know if the dual agonist receptor will provide anything more in the way of cardiovascular benefit. We do know that by indirect comparisons, they do appear to produce more in the way of weight loss and more of the way of hemoglobin A1C reduction. You know, it's always an interesting question of how do you identify higher risk patients. As you know, risk equations for secondary populations don't work that well. I mean, we certainly do identify some patients that we consider to be extraordinarily high risk. And I think we did see, since we saw a similar relative risk reduction, that you could expect those who across all the different subgroups, if you identify higher risk patients, that's certainly who you want to focus. But you know, in the end, we have a population of patients who were fairly well treated, as you can do in a large trial. You know, this was a multinational trial. To have that degree of blood pressure control, to have that degree of LDL control. Even in lipid trials, you rarely have baseline LDL of 78 milligrams per deciliter. So this represented a group of patients that were getting the contemporary standard of care. Now, could you improve it by better lipid control or adding anti-inflammatory? Certainly these aren't mutually exclusive approaches, but I think that in the end, this is a different approach that was superimposed upon the traditional risk factor pillars that we've been working with and showed additional benefit. And hopefully, as economic pressures become less with competition and with other agents that are coming down the pipeline, the economic pressures against broadly treating will become less so, and we can provide these treatments to more patients who I think would benefit.
Thanks, Michael. Tim?
Yeah, let me, as Michael said, these patients, I think 80–90% were already on statins, and 60 or 70% of them, their blood pressure was controlled with angiotensin blockade. And then we had 20% risk reduction in the hazard ratio on top of that. When we look back to the statin trials decades ago, they on balance led to about a 30% reduction in the hazard ratio. And so this 20% is very remarkable. These drugs, at least for secondary prevention in patients with overweight or obesity, are at least as good as statins. So we should look at them in the same regard. I mean, if we think it's so important to use statins, we should have equal emphasis on the use of semaglutide for secondary prevention of cardiovascular disease and obesity. And to go back to Geltrude's statement about bariatric surgery, let me add to the benefits there is there's a meta-analysis showing a 50% reduction in cardiovascular in MACE events and in myocardial infarctions, so which far exceeds anything that statins or semaglutide can give us, at least in these patient populations. So, I think I have to double check your math there, Carlo, on the numbers needed to treat. I'll believe what you say, but I thought it was a lot lower than that. But maybe Michael can comment on that. And do you want to transition
per year of treatment? It's per year of treatment, Tim.
Oh, per year of treatment. Okay.
You may have in mind a lower figure for the whole duration of the trial, but if you want to compare it to other preventive strategies, you need to express it per year of treatment.
Right.
Carlo is our, master regarding the number needed to treat. So please don't be very quiet speaking about this. Gertrude, do you like to comment, or I see Massimo that...
I just like to say something about Carlo told before. The effect of semaglutide on body weight is more remarkable than 9%, because there is a 15% weight reduction, as shown in the New England Journal of Medicine on the trial on obesity. The problem is that looking at different trials, we can see that people with type 2 diabetes lose much less weight than people without diabetes, which is a puzzling, a very important issue. About half of the body weight lost in people without diabetes. And therefore, sometimes there is a misunderstanding with the weight reduction of drugs like semaglutide, for instance.
Okay, first, before to give the possibility to Massimo to speak, I would just like to read another question from our chat. One question was about statins and the contrasting effects between statin user and non-users, but I think that Timothy has already answered the question. And then there are a lot of concern about female. Please, after Massimo questions, say something about female, because of course they, are more subject to obesity.
Well, I'm actually saying something about children, because
and children too.
I read a very interesting report on Lancet from Ezati, who's it's very concerning, because now 1 out of 8 people in the planet has obesity, And so the overweight has overcome the underweight and in the planet, which is interesting. And 160 million children and about 900 million adults are obese. So people in the countries is concerned that the policies to prevent obesity are outdated, and this is particularly, felt in UK and United States. So maybe our government and the healthcare policies should change to really impact on prevention of obesity, because all these wonders we are talking today about the new drugs and bariatric surgery cannot resolve the problem of 1 billion people and so many children. So if you can, the panel can comment on that. We don't have a recipe to resolve the problem, but maybe that's an interesting point.
Yeah, Massimo, that's a critically important point. I think it's a slow boat to turn around. Let me put it that way. I think it's one aspect of this has to begin with the built environment and patterns of life in terms of how sedentary we are. And also access to unprocessed foods and our inclination to eat more healthy diets. All of that would have to change. Our governments and regulatory agencies would have to engage in more health messaging. And I think another important aspect of this is the in utero environment. In a sense, this leads to the intergenerational transmission of obesity. We know that mothers that have gestational diabetes or obesity, their offspring are more likely to have this as well. And there's been epigenetic modifications identified in association with this. Doesn't let fathers off the hook too, because they can, have epigenetic modifications in their genome as well. But just preconception health is something we have to pay attention to as well. So it's multifactorial, but we really have to get serious about this and be advocates for the prevention of obesity in our different communities.
Gertrude, you have a comment?
Yeah. Of course, it's very important to prevent obesity, and education is the most important way to convince people to increase physical activity, to change the habit. We know, however, that the compliance of people is pretty poor, and therefore it would be great to use drugs for like metformin. We used a lot metformin for preventing type 2 diabetes, and it is indeed effective. The problem is that metformin is cheap, while the new drugs are very expensive. So we need to choose between treating obesity or preventing obesity. And I think treating obesity at the moment is very important. We can work on education to prevent obesity.
Actually, there are several questions about this. In particular, Jonathan Herman is asking to all of you, to our panel, what they think about strong lifestyle, healthy behavior, things like this. I would like to add a little comment. What do you think? That after drugs like semaglutide or even a double agonist, people feel more, comfortable to also adopt an healthy lifestyle and to do exercise, to eat better or not. Or people will say, okay, I'm taking a drug, so I can do whatever because I'm taking a drug that will make the miracle.
Giovanna, when you take a drug like GLP-1 receptor agonist or double agonist, you lose appetite. At least in the responders, there is a reduction of appetite and increase the satiety. So the patients can easily follow a diet. I always say to my patients, it's not your fault, you have a disease, so you are not able to keep doing the diet and doing physical exercise. But patients lose 5-6 kilograms in a short period of time. He or she are very happy to continue following the diet. But the drug is important because it's not their fault. These people are eating a lot also because they have problems. They are depressed. They have increased appetite for a series of reasons linked to satiety hormones or appetite hormones. So we know a little about appetite and satiety still now. So I think that the patients want to lose weight, they want to keep doing dieting and physical exercise, but are not able to do it.
It's also interesting. It's also interesting that food choices seem to change, and this is, there are data that as patients are on these drugs, that they will spontaneously less frequently as they're shopping buy less in the way of sweets and calorie dense food, less in the way of high fat foods, focus more on vegetables and protein rich foods. And this is just, as spontaneous. So their appetite is reduced, but there's also an effect on actually their desire or the foods that they're interested in. And as I'm sure, we've all heard, it's being studied. There seems to be effects on, alcohol, less in the way of alcohol, interest in alcohol, less in the way of gambling. I mean, this satiety centers not just on how much you eat, but on a lot of behaviors.
I see some hands, Filippo, and then Carlo. Filippo.
Yes, I have a question for Michael and team, and the question is about BMI. We are acquainted with BMI, we love it, actually we hate it, but BMI. Now, we know that waist to hip to waist ratio is a better predictor. Salim Yusuf was one of the first to show that it's a much better predictor than BMI. And now we know Garalambos-Antoniades showed very clearly that PVAT, perivascular fat, is a much more accurate predictor of risk. So what do you see in your crystal ball in future trials? Should we go for BMI, waist to hip ratio, or FAI, the fat attenuation index? I mean, I think it's important not only to have good drugs, but also good targets.
Yeah, I mean, from my standpoint, BMI is a good population-based, easy to measure and helpful in observational studies and also in randomized trials. But certainly, it doesn't necessarily reflect dysfunctional body fat, and particularly in various ethnicities or national origin. We know South Asians, for example, the BMI cutoff of 30 for obesity probably is too high, and that the metabolic effects may be substantially lower. And there's interest in doing studies of lower BMI thresholds at 23 or 25, even for consideration of what might be the physiology of overweight might benefit. We have a nice paper that my colleague Donna Ryan, who was the chair of the study, is much more on the anthropometric outcomes and the details from SELECT. But you think the goal is that there are multiple ways of looking at what is dysfunctional body fat. Obesity and overweight really aren't just a body size issue. They really relate to but how to apply that in populations is different from how to apply it to individual patients when you assess whether or not they might benefit from these types of interventions.
Carlo.
So there is no question that we are dealing with a highly effective class of drugs. What about safety in terms of short-term safety, long-term safety? And I'd like to ask the question of long-term safety to the panel based on an interesting paper which was published last week in JAMA a study using the Million Veteran Study as well as the UK Biobank as two independent populations to assess the impact of fluctuations in BMI on the risk of major vascular events, and showing an association between fluctuations in body weight and the risk of major vascular events. Now, when dealing with marked body weight reduction, we should also expect marked body weight gain when people stop taking these drugs. So is this a potential concern about the long-term safety of these newer agents?
Michael, you want to take that?
I can start. It was certainly, I think it's been fairly well recognized, and as you pointed out, recently reviewed that the fluctuations are adverse. And of concern with these drugs is that when people regain, they may not be regaining the same way that they lost. So the weight loss with these drugs is more fat than muscle, but there is lean muscle mass reduction as well. And so when they lose the weight, their percentage of body muscle, lean muscle, increases as a total, but there has been a decrease in their lean muscle. But then when they regain, it's not necessarily clear that they regain in the same ratio. So these cycles of loss and regain may actually lead to less in the way of lean body muscle mass, which of course has important metabolic consequences. So I think that may be part of it. And I think it raises the whole question of whether or not we should also be looking at development of agents that are anabolic from the standpoint of maintaining muscle mass, or lifestyle interventions in these patients at the same time to improve lean muscle mass. Not only at the time to prevent some of the effects of fluctuation, but also I think as a healthier metabolic milieu.
Thank you, Michael. Tim?
Yeah, this is a concern. Interestingly, there's a real effort to use kind of anti-myostatin, anti-activin 2 agents, as well as apelin as a muscle stimulant, combining that with GLP-1 or dual agonist to kind of preserve muscle mass or even accrete muscle mass during weight loss interventions. And that, I think we can look forward to that in the future. And when that happens, BMI is no longer going to be any way to evaluate these patients over time, because lean mass is increasing and fat mass is decreasing. And, we're just going to have to measure body composition to accurately follow these patients.
Yeah.
Okay.
Geltrude, do you have any comments?
Yeah, I mean, also with every kind of lifestyle intervention which allows a rapid weight loss, we lose muscle, because the first type of metabolite we use are amino acids, which are used in the liver, in the muscle, and therefore everyone losing rapidly weight is losing muscle. And there are also pharmaceutical companies looking at drugs which are able to increase muscle mass. But I think that physical exercise is of the utmost importance. Also, for instance, in patients who undergo bariatric surgery, they have the same problem.
I don't want our audience to think that we can't get patients to lose, 20% of body weight and worry too much about the muscle mass. It's definitely an area for further study, and we have to be attuned to this. But I mean, with bariatric surgery, with these medications, and at least in my experience, even with phase 3 trials, with other medications in development, patients lose a lot of weight, but I haven't been convinced they have a lot of dysfunctional muscle or impaired physical activity. In fact, their physical activity capacity increases because they're carrying around less weight. We have them walk up a number of stairs before and after treatment, and I just haven't been impressed that it's a big clinical problem, at least in the short term. So don't be wary of this, but don't let that stop you from treating patients as aggressively as needed.
Filippo.
I don't have questions, but I'd like to involve Professor Braunwald in this discussion. His wisdom usually is enlightening. Jean, comments from your side or questions?
Yeah, let me, can you hear me? Good.
Yes, very well.
Yeah, so my comments, first of all, I think we have to congratulate Michael Lincoff. I mean, this is a home run out of the ballpark. So that's terrific. The second point I want to make is in the last 10 years, 2 classes of anti-diabetic drugs have been shown, the gliflozins and the weight loss drugs have been shown to have more profound effects. Yes, they're anti-diabetics, but the impact they're going to have and are beginning to have are just extraordinary because of the breadth. It makes me wonder, are there any other anti-diabetic drugs that we could look at for the heart? Then the last point I want to make is that in addition to this wonderful paper, I think the effects on HFpEF of this class is very profound. And so it's a terrific time to be alive and to be able to help so many different classes of patients. We've had a period where things are pretty dull for a while, and in the heart failure zone. And this is a magnificent turnaround.
Jean, let me add one conceptual point there, is that I think we can think about these drugs as treatment of cardiometabolic disease.
Yeah.
And all of its end-stage manifestations, which include cardiovascular disease, heart failure, diabetes, NASH. These are single agents that can ameliorate all of those end-stage manifestations. Of course, insulin resistance is at the core of this disease progression. But at the state of the art now, as we wait till patients get one or more of these end-stage manifestations, they're at risk of getting all the others. We send them to subspecialists. They get treated with individual medicines. They end up on polypharmacy. I think we can look towards the future of using these weight loss medications as single agents that can treat or prevent a broad array in the cardiometabolic disease nexus.
Okay, I see Nick Finner that was the second to ask a question in the chat, but I think I would like to ask by himself. Please, Nick.
Sure. Well, Michael, you sort of mentioned the legacy effect, and I guess there are 2 things which I just wonder whether you've had a chance to look at. We know that these people had their pre-diabetes disappeared during the SELECT trial, and we know that the legacy effect from preventing diabetes lasts 20 or 25 years. So that's one potential legacy effect. The other, which I was curious about, there were a number of patients who discontinued. You mentioned that the benefits accrued before weight loss. So I just wondered if you looked at the patients who discontinued, did they actually have benefit in terms of reduced outcomes? In other words, was that early benefit maintained independent of the weight loss?
So there's been a lot of interest in looking at dose, and not only discontinued or not, but those who didn't reach the full dose, because we did allow. The problem is that patients were allowed to shift back and forth multiple times. There was no permanent. So it actually turns out to be a very difficult analytical approach. And so I have to say that we don't have any good evidence one way or the other. We're still trying to sort it out, but it's very difficult.
Thanks very much.
We have
an extension study of SELECT of about 4,000 patients that are continuing on that we'll follow for 10 years. So hopefully we'll have maybe some legacy effect type information.
Okay, we have really many questions from the audience. Many questions are about the direct comparison between these second generation drugs and bariatric surgery. We have already said a lot about this, but in particular, there is a question coming from Michael Oningberg about if it's possible to select people for semaglutide or tirzepatide, and on the other side, people to bariatric surgery, even in a more contained BMI range. So not really more than 40 or something like this. If it's possible to identify subsets of patients. And what do you think? It's possible to identify subsets of patients that may benefit better than these drugs? There are several questions about this.
The problem is that we are working with the surgeons who have the major problem to ask the patient which type of surgery they like, which is unbelievable, because we don't ask to the patients which kind of drugs for the type 2 diabetes would you like, or for cardiovascular diseases, which means usually the doctor decides what to do. And therefore, there are not clinical trials which are unbiased. So very few randomized controlled trials. The problem is that pharma is not willing to compare drugs with metabolic surgery. So it's very difficult to know which category of subjects or people should undergo only bariatric surgery or anti-obesity medication. So what I can say is that pharma just enrolled the patients with a body mass index up to 38. And there are very few patients with the body mass index higher. So there is a lot of way to do in the future.
There's a lot of information to compare the amount of weight loss, but there's very little information to compare the cardiovascular benefit of the two approaches. All the data for bariatric surgery is observational. And there have been a lot of, some of them are quite large and they do what they can to correct and propensity match, et cetera. But the bottom line is that we don't really know the magnitude of treatment effect. I have no doubt that cardiovascular risk is reduced by bariatric surgery, but is it 20%? Is it 40%? Is it 50%? So at least in my mind, I think we're mainly thinking about where do patients start, and if for no other reason, for what magnitude of benefit they'll have for the other benefits of weight loss unrelated to cardiovascular, and with the anticipation that a substantial weight loss should hopefully yield similar cardiovascular benefits.
Can I ask a last question? Coming back to lifestyle, what about prolonged fasting? Interesting mechanistic studies, but less convincing epidemiological data. What are your feelings about it? Mike, team, Gertrude?
There is a study published in the New England Journal of Medicine saying that at least intermittent fasting doesn't work really. So whatever they do, the patients, a low-calorie diet, it's effective. Very low-calorie diet can work for a limited period of time and then followed by low-calorie diet. But in order to keep following the diet, they need to reduce the appetite in any case.
Okay. So I think we have, we need to close because it's already 1 hour that we are enjoying each other. So a closing remark from each of you, Michael, Timothy, and Geltrude, and then from Filippo Crea, the last word. Michael.
So I think the most striking point from the standpoint of the cardiologist is this has now become our problem as well. We knew before that patients with overweight and obesity were at risk, but there was nothing we could do about it. And now it's become our responsibility. And just as in decades ago, cardiologists didn't treat lipids we now treat lipids, I think this becomes something we have to address in the current era.
Tim?
Well, I think I'm the only endocrinologist on the panel, and I'm happy to have the cardiologist join us in this quest. You know, I view the advance of these medicines, I think we're in an era which really represents a landmark in the history of medicine, on par with insulin, on par with penicillin. When you consider how common this disease is and the amount of patient suffering and social costs it exacts, and the efficacy of these medicines, 2 second-generation medicines available now, more on the way. I think it's going to be transformational if we can find a way to kind of have sufficient access across the board to these medicines in terms of affordability, and which is a big problem.
Geltrude.
Even just to clarify, I'm not surgeon, I'm cardiologist too.
Oh.
So I'm
That's disappointing.
I'm happy that we have now new drugs, new anti-obesity medication to treat obesity, and I'm looking to find even more effective drugs like cagrisema and many others, retagrutide, so on. So I like medicines rather than surgery.
Filippo?
No, well, 2 things. First, thank you very much, Michael, team, Carlo, Giovanna, and Geltrude for this, Massimo for this wonderful dialogue. And I'd like to announce the next dialogue will be, as usual, on the last Thursday of the month, will be on the 25th of April. And next dialogue will be with the Nobel laureate, Lou Ignarro. He was awarded the Nobel Prize for the discovery of nitric oxide, which we know has been very important for our life. So please join us for the next dialogue with Lou Ignarro, and thank you again to all of you for this wonderful time we'll spend together. Bye-bye.
Bye-bye.
Thank you to all of you, and a special thank to Professor Braunwald, because it was really a great honor to have the possibility to have his comments on this topic. Thank you. Bye.
Happy Easter. Bye-bye.
Happy Easter.
Bye-bye.